Good afternoon, everyone. My PhD thesis title is about the new insights on the prognosis of pancreatic ductal adenocarcinomas. My name is Lőrinc Ulmann. I'm a surgical resident here at Semmelweis University, Department for Surgery, Transplantation, and Gastroenterology. My supervisor is Akor Such, and my SMS is Mahmoud Obaidat. My vision is to be able to combine the research and knowledge in the surgical field of pancreatic cancer. And in order to achieve that, we are planning to research how the different pancreatic tumor mutations lead to a different prognosis. I have two specific goals with two specific projects, and I will talk about those at their current slides. So my first project is about investigating the prognostic relevance of micro-RNA analysis of pancreatic ductal adenocarcinomas, or PDACs. I have started this project in September 2023, and I'm planning to publish it in December. In order to introduce the topic, PDAC is one of the worst prognostic cancers in the world, with a 5-year survival rate of around 7%. And therefore, what do we tell the patients? Is this only a homologously bad survival rate tumor type? Well, one possible solution for this could be micro-RNA analysis. Micro-RNAs are a group of nucleotides that act the development of cancer as acting either as oncogenic micro-RNAs or tumor suppressor micro-RNAs. Therefore, my aim with this project would be to investigate the prognostic relevance of these biomarkers in PDACs. We are planning to answer the question, could the newly researched micro-RNAs give a precise information about their prognosis? Therefore, our population would be patients who are actually diagnosed with PDACs. Prognostic factors would be measured in high and the low expression of microRNAs, and the outcome would be measured in overall and disease-free survival. We are hypothesizing that the change in the microRNA levels in patients with PDACs is actually associated with a worse prognosis. We have conducted our systematic search in 3 different databases, and you can see our search key here. I would like to outline key articles. This is a highly researched area with a vast amount of microRNAs, and they are investigating the same outcome in terms of the different microRNAs on the same population. You can see our flowchart of selection here. We have started out with 11,000 articles, and we have reduced this number to 148. We still have ongoing analysis, thus we only have preliminary data. But we already know our strengths and limitations from the preliminary data. We have seen that these microRNAs do show an association with survival data, thus could possibly predict the prognosis of different PDAC types. And we have included numerous vast amount of microRNAs. And our limitations would be that we do need to compare the same microRNAs, which we don't have yet because it's only preliminary, and that this is a heterogeneous population with different therapeutical groups. You can see our progress for the first project here. We're still waiting for the final figures and tables. So in order to introduce my second project, that is about comparing the prognosis of patients treated with borderline resectable pancreatic cancer that receive either neoadjuvant therapy or surgery alone. We have started this project in November 2023, and we're planning to submit it in December 2024. In order to introduce the topic, there are 3 types of pancreatic cancers. In terms of the treatment, there's resectable, borderline, or unresectable pancreatic cancer. However, in all of these cases, surgery is actually the only chance for survival. However, only actually 15 to 20% of these are actually resectable. And you can see that without resection, the 5-year survival rate is only about 7%, but it does increase with resection to 15 to 30%. And you can also see the same pattern in the borderline resectable group. Thus, our aim with this project is to investigate the effect of neoadjuvant therapy and primary surgical resection on the prognosis of borderline resectable PDACs. We are trying to answer the question, is neoadjuvant therapy safer and more effective in the treatment of borderline resectable pancreatic cancer than primary surgical resection? Thus, our population is patients who are actually diagnosed with borderline resectable PDACs, and we are comparing preoperative neoadjuvant therapy or surgery alone. Our outcomes will be measured in overall and disease-free survival, percent of operability, and turnover rate, our zero resection rate, reoperation rate, and the post-operative complication rate. We are hypothesizing that neoadjuvant therapy is safer and more effective in the treatment of borderline resectable PDACs than primary surgical resection. You can see our key articles here. I would like to outline that this is a very new topic, which is highly recently researched, because only 4 of these outline articles are actually published in the summer or spring of 2024, and they all investigate the same population with different neoadjuvant therapy types and comparing them to primary surgical resection. So you can see our second project's progress here. We have decided that the topic is feasible, but we're still working on our Prospero. And as a summary, I have 2 ongoing projects, and I'm planning to submit both of these in December 2024. And I would like to end my presentation with a quote from John D. Rockefeller: "If you want to succeed, you should strike out new paths rather than travel the burned paths of the accepted success."
Congratulations.
Thank you.
Nice presentation. Is there any data in the literature that maybe micro-RNA profile affect the response to the chemotherapy?
There is actually. First, we have been primarily investigating just the prognosis itself, but we have also looked at, we don't have the data yet, but we have also looked at the different microRNA types and their effect on the chemotherapy agent sensitivity. So yes, there is actually.
Do you examine the pattern changing of the profile, or do you examine the ratio between the benign and malignant micro-RNA changes? Or,
yeah, we are only looking at the malignant types, and thus in all of these studies, they have looked at the sample preoperatively and postoperatively, since all of these patients have received surgical resection in the first project, and therefore we are looking at the change. Yes, we are looking at the change in patterns, but only in the malignant types.
Okay, thank you.
How big portion of your patients receive neoadjuvant therapy?
Around 60-70% of these that we have included in our study, and we can see this is only because actually we have in the first project we have only included the ones that actually have received surgical therapy, and thus this is only 60-70% of them. But in the real world, when there's no turnover, for instance, a lot more of these patients have received neoadjuvant therapy.
Okay, so it's becoming more and more of a standard procedure. And what are the criteria? Can you tell us for a patient to have a neoadjuvant treatment?
Well, in terms of borderline resectability, if the local areas are already outgrown by the tumor, for instance, and if there's metastasis, when surgical therapy cannot be primarily used, for instance.
Yeah, but that's called palliative treatment.
Palliative treatment,
it's not neoadjuvant.
That's not neoadjuvant, but in the borderline resectability, such as arteries or veins are infiltrated. Yeah.